I'm Shirley Marks. I'm a board-certified psychiatrist from the Dallas area. And I never expected that I would not only be presenting today, but presenting in front of law enforcement. So if I get a little antsy and nervous and move around a little bit, it's a new experience for me as well. But I appreciate the invitation, and I think it's an appropriate topic given these times. I don't know if you've read the brief bio, but I retired from the VA. And I started at VA in the 70s, so I have a perspective of having had the opportunity to evaluate and treat. So I knew that would happen. That's why World War I veterans and World War II, and then of course now we've got our OEF, OIF veterans. And I was away for 12 years, returned, and it's an unfortunate experience with these wars that we're in now. And after I retired, it's been about a year now, I then went to Fort Hood. So I had an opportunity to work with active military soldiers firsthand. You know, many had just returned, talked also with some who were involved in the Fort Hood shooting. And so it was a good opportunity to round out my career also. So Ron asked me today to talk to you a little bit about post-traumatic stress disorder and TBI, or traumatic brain injury. Have you heard of these terms? These are not new terms to you, correct? Now, in this short period of time, I'm not going to be able to cover the entire subject. And one of the areas I'm not covering is treatment, because I don't think that would be appropriate for you as a group, but I do hope that this will give you a general overview, and also in your, whether training or when you go back to your home base, that you familiarize yourself with the referral sources, because I think that's where you come in terms of, we don't expect that you're going to provide treatment, but your interventions can certainly impact treatment by the referral. And if there's some jail diversion programs in your area, that would also be helpful. And again, this may be appropriate for some of you in the audience. I know when I evaluated many of the active military, as you may know, with the economy the way it is, so many of our young men and women are volunteering for the military with no skills when they go in. So their skill is knowing how to shoot a gun. So when I asked them, because I did a lot of the medical boards, what their plans were after military, many of them wanted to be law enforcement police officers. I did not support that, but you know, because I'm convinced that some of them did have PTSD, and it's not the best profession to be in, but that's what they felt that they were qualified for. So this may be a self-profile for some of you, and if so, hopefully it'll be helpful for you. So I suppose then we'll just get started. I'm supposed to give him the 1, 2. Okay, so let's start off with post-traumatic stress disorder, or PTSD, as you will often hear it named, and I'll just say PTSD just for brevity. The diagnosis depends on, first, an exposure to trauma. That has to be there. I mean, someone coming in and saying that they have PTSD or whatever, it's important to determine what the trauma is. And a development of a specific pattern of symptoms that appear following the trauma. Now, this is focused on veterans today, but I always have to say as an aside, this could be rape victims, as you know, with the tornadoes, Katrina, any life-threatening event, this would be a trauma. Even in urban areas, oftentimes not thought of, but even in urban areas where people are exposed to gunshot, fearfulness, you know, just all kinds of death within their own immediate environment, and where they're involved with the police and law enforcement on a regular basis. So the focus today is on veterans, but I have to say that as an aside, because I want you to know that this is a broader subject. It was not, the diagnosis is not specific to veterans. So even when we first started using the term, it was not unique to veterans. So PTSD is not a new element of war. Throughout the years, it has been called insanity, melancholia in the Civil War. And we don't have many records of that, but what we do have are diaries from families or widows who would describe the way their husbands or loved ones would come home And some of you have probably even seen some old movies where they might have somebody waking up from a dream or whatever. So it's not new in terms of symptoms, it's just new in terms of what we started naming it or calling it. I'm not ready yet, go back, sorry about that. And during World War I, we called it shell shock, and I would diagnose patients in that era when I would see the big, thick VA records, and they would have shell shock in there. And then as we progressed to World War II, because when I started VA in the 70s, there were just a few World War I vets still living, but quite a few World War II. POWs, I interviewed quite a few of those, and all through the record was combat fatigue, combat neurosis, and so it wasn't until the 80s that the diagnosis of post-traumatic stress disorder came about, and many were diagnosed decades later. One of the unique things about this disorder is that keeping busy, having a structure, being in treatment is very important. So what happened back in the 70s, the World War II vets were retiring. And many of them, I'm sure you have grandfathers who, I don't want to get ahead of myself, but didn't talk about the war. They came home, married maybe their high school sweetheart, and went straight to work. But they stayed busy. And when they retired, these symptoms came with a resurgence. And for some of them, it scared the daylights out of them. And they would, they were flopping and falling out of bed. Their spouses didn't know what the problem was. And maybe a neighbor would say, I think you need to go to the VA and have it checked out. So that really was what was happening in the 70s. And I was one that experienced that, being a psychiatrist at that time. And well, I was really at the Houston VA at that time. So when the diagnosis came about, again, it was not unique to veterans, but this is when we started recognizing this as a real entity and diagnosing our veterans and active military. It's now referred to as the defining military health issue of our era by the U.S. Army. And it's estimated that in a U.S. Army study that about 8 to 14% of all infantry soldiers, now this is just soldiers, because as you may know, Navy, Marines, so there are a lot of military in these wars, but this is just an Army study, that at least 8 to 14 of them returning from Iraq and Afghanistan have major mental health problems. And they are now required, at least in the Army anyway, to have all soldiers who were involved in combat to be evaluated by a mental health panel. And sometimes they get the evaluation and don't always get the treatment, but at least there's a step toward that. And then within the VA system, there's a program designed, but we don't have enough time to get into the treatment of that. But at least the Army recognizes that this is a serious problem. So what is the definition of PTSD? I've talked about it, and you probably know about it. Probably most lay people just know that they have nightmares, but PTSD is really more than that. It's the development of characteristic and persistent symptoms along with difficulty functioning. And functioning can be in a lot of spheres. We've got social, occupational, and personal. Again, I don't have time to go into all of that, but you can imagine that this is a pervasive malfunctioning situation. After exposure to a life-threatening experience or to an event that either involves intense fear, the tornadoes, the house is going to crash in. I was actually caught in Katrina in Mississippi at that time, so I know about that. That involves intense fear, helplessness, horror, or serious injury. And so again, whether that's combat injury or whether that's some other type injury as we're experiencing with people with the tornadoes at this time. And I added at least 1 month duration because there is acute stress disorder that you may or may not know that term, but again, beyond the scope of this presentation. And acute stress you might encounter with persons in the community, because this is an immediate response within a month of whatever the event is, but it does not last longer than 4 weeks. So we call that ASD, but acute stress disorder. So anything that's longer than that and you might even yourself experience it if you're out there, in the field and there's something very traumatic, or or involved in a very grotesque situation, you may have noticed that you had some sleep disturbance or some irritability, but it went away, that you might have had some debriefing or whatever, and those symptoms pass. But you might yourself have experienced some acute stress disorder. The symptoms may disappear with time. This is not one of these disorders that won't remit. So they may disappear with time. Many persist for years and may coexist with other psychiatric conditions. So we talk about 3 clusters of symptoms, and this is the point that I was making about just the nightmares, because typically PTSD can be overdiagnosed, even within our profession and counselors and all, because the intrusion or re-experiencing, that's the main one that most people know about, most lay people, even within the mental health profession. These are memories of the trauma or flashbacks. You hear people talking about flashbacks. Flashbacks are visual and that occur unexpectedly, come on, surprise the person. May include nightmares, intrusive mental images, or extreme emotional distress, and or physiological reactivity on exposure to reminders, triggers of the traumatic event. Now what that means is, now it's an interesting phenomenon for my having worked in all of these wars, about 5 wars. For the Vietnam era veteran, because you can imagine they were in the bush, so their trigger was often, and at that time, Asian, because now we're a melting pot. So an Asian does not trigger our OEF, OIF veterans as much, but at that time, very much so. Some guys had a lot of difficulty with that. Diesel fuel and the smell of diesel fuel was a big trigger back during that time. One of the more common triggers now is driving along in your truck or your car and you're just having a nice time and you see a black garbage bag on the side of the road, because the danger is different now. The danger may be a suicide bomber driving right into post and blowing up everything. So you're always hypervigilant. I'm getting a little bit ahead of myself using that term, but you're always hypervigilant, so you may have those kinds of triggers. So this is the intrusive or re-experiencing cluster. Now I've put asterisks here because avoidance and emotional numbing is the one that truly is the best indicator of PTSD. Okay, so it's not the nightmares, which more typically is what people say, well, they have nightmares, PTSD. But it's the avoidance and emotional numbing. Even the research supports this, that if this is present, the majority of the time, high percentage, you're going to have PTSD, unlike the nightmares. So what is that? Avoiding people, places, thoughts, or activities that bring memories of the trauma. And you get it all the time. I can't go to Walmart. Well, I don't go to Walmart either, so that's not, to me, the big indicator. It usually is something else. Oftentimes, there may be large crowds, loud noises, but it's not just the open spaces, because sometimes people with agoraphobia or panic disorder, which is not the same as PTSD, may not want to go into Walmart or the big stores. This may involve feeling numb or emotionless, withdrawing from family and friends, or self-medicating by abusing alcohol, illicit drugs, or pain medication. And this is oftentimes what the families will report. So it's important that if you are responding to a domestic violence issue or whatever, and you have an opportunity to get collateral information from families, that you may find that the person withdraws. And you hear this from veterans a lot. I don't, everybody was out having fun, grilling, and I just didn't want to be out there. Or I just didn't want to travel with such and such activity. So they're more isolative, and while describing or talking about the trauma, and this is what they mean by the physiologic reactivity, there is the physiological response, whether anxiety, sweating, that kind of thing. Next. And then the last symptom cluster is hyperarousal, feeling on guard or irritable, having sleep problems, having difficulty concentrating, feeling overly alert or hypervigilant. We use hypervigilant quite often, and being easily startled. You've heard startle responses. Having sudden outbursts of anger. So if I'm here and I think I do have a little bit of PTSD. I don't really have it, but Katrina really was scary. But if you hear a loud noise out in the hallway, some of your own might jump, you know, and might jump far. So that's the kind of thing with startle response, and that's what they're referring to here. Or you may have some difficulty concentrating, or irritability, and not being able to sleep. And so self-medicating, drinking, you know, alcohol in order to sleep can get out of hand, and that's why sometimes vets and people become addicted to alcohol. And also with pain medicine. You know, if a soldier comes back with disabilities or injuries and gets started on pain pills, and then that gets out of hand. Now, I've indicated here functional assessment, not so much that you would do the functional assessment, because again, I don't want to move into a treatment track, but it's important for you to have a sense of the overall functioning if you're going to actually be out in the community, or if you're trainers. I don't know all of the audience here. But these are the areas that are impacted by someone who has PTSD, and that would be work. You know, are they working, and, you know, are they having, going postal, as we say. School, if they're younger, many of the vets now get large educational benefits, so they are able to go on to college. Recreation, are they avoiding recreational activities? Do they enjoy the recreational activities? Do you hear family or the children complaining that dad or mom are not wanting to be involved in recreation as much? Housing, very important. Are they homeless, or the housing is stable and satisfactory? Financial, you know, not being able to work, getting laid off because of days missed. So what is the financial situation? And then, of course, community involvement. You know, if you got somebody who's very active in the community, that's a good sign, because they're staying busy even in these trying times. They may not be gainfully employed. Now, on the right side, I've indicated in red legal and family relationships, because I think if you're going to be involved on a one-to-one basis with some persons with PTSD, you're likely to see these kinds of problems. Legal. Are there outstanding warrants, restraining orders, or disciplinary actions? Is the person regularly engaging in or at risk to be involved in illegal activity? Is the person on probation or parole, and if so, for what reason? Are they violent, nonviolent type issues? And is there family advocacy or Department of Social Services involvement, or whatever it's called in your state or locale? And with family, again, if you're getting collateral information from family members, negative changes in relationship with significant others, used to be outgoing, now doesn't like to go out, doesn't enjoy the family outings, doesn't enjoy family reunions, irritable or easily angered by family members, very impatient with the young children. It's really sad when you hear some of the, well, active military even, who've been away 11 months and they've got 18-month-old children. You know, they've been away more months than that child has been alive. So that's an unfortunate thing. And then they may come back, be very irritable, not like all the noise and all that in the household. Withdrawal of interest in or time spent with family. And of course, any violence within the family. Now that's very, very important. I know if you're in that capacity or training persons who are responding to domestic violence calls, it's very important to know what it is you're dealing with that. Now, PTSD very commonly, high percentage, coexists with other mental and psychosocial conditions. And some of them are medical. Of course, chronic pain makes sense, because if they've had some traumatic exposure, many of them do have physical injuries. So they may have chronic pain, TBI, some mobility limitations. They may have prosthesis, or they may have difficulty ambulating. And so if you know that, you know, and this is a young man or with a cane, you know, already you know, the more common thing would be to think, you know, is this a veteran of one of our wars? Substance use disorders, or you may use the term substance abuse. We say substance use disorder. 40 to 50% of PTSD veterans treated at VA facilities have substance abuse problems, and that percent may even be higher, because as you may know, within the veteran population, high percentage have substance use disorders. And in psychiatric, they may have, these are conditions that coexist with PTSD, depression, anxiety, panic disorder, psychotic disorders, which are more severe but still can coexist. And then I've added eating disorders with women. Not only if they're women veterans, but this is very common for women who have been abused or raped, whether as a child or as a stranger sexual assault. So if you hear of eating disorders or even women who have a lot of chronic pain going to ERs, oftentimes there's some assault or trauma in their past. Personality disorders often coexist. Now, if you're keeping up with the media, I don't know how many of you are veteran, this is a big hot topic right now, because I'm going to digress a little bit and explain the medical boarding process. Personality disorders start in childhood and adolescence. We say adolescence, so we're not getting into what that age break is. So the VA says, and the military says, we did not cause that disorder. All right? So what happens at board time, a lot of soldiers or active military who are trying to be boarded out, or even at the VA, if they have significant personality disorder symptoms, are often not diagnosed with PTSD, or if they have personality disorder, they may have a poor adherence to treatment if they do have PTSD. So this is coming out more and more in the media, because many persons who have personality disorder are either not granted their disability, but it's, you know, personality disorders are a real phenomenon. And then, of course, psychosocial problems. Again, I've highlighted them because this may be what will impact you, either you individually or if you're training your colleagues. Homelessness. Okay, this is not just, you know, many, as you know, many homeless are well-educated people, but think of some of the things we've talked about already. They may have had substance abuse, violence, divorce, lost home, they're now homeless. But, you know, the etiology behind that. So homelessness, suicidality, and I've included suicide by cop, domestic violence or abuse, and explosive aggression. Now, I have a little something that I'm going to read here. I'm not using his name because I don't know if there are any copyrights to this story, and some of you may already know about it. It won't take very long, but I'm going to call him Tom Brown. This is from North Dakota, and the title of the paper is "Suicide by Cop Leads Soldier on Chase of His Life." Okay. At 8:20 p.m. on September 21, 2010, Iraq veteran Tom Brown decided it was time to die. He lurched from his black Tacoma pickup truck, gripping a 9mm pistol. In front of him, a half-dozen law enforcement officers crouched behind patrol cars with their weapons drawn. They had surrounded him on a muddy red road after an hour-long chase that reached speeds of 105 miles per hour. Brown stared at the ring of men and women before ducking into the cab of his truck. He cranked up the radio. A country song about whiskey and cigarettes wharfed out across an endless sprawl of North Dakota farmland, stubbled by the recent harvest. Sleet was falling, chilling the air. Brown, 29, walked slowly toward the officers. He gestured wildly with his gun. "Go ahead, shoot me. Please, shoot me," he yelled. His voice illuminated in the blazing spotlights in the deepening darkness. "Do it, pull it. Do I have to point my gun at you? Do it." 20 feet away, the officers shifted nervously. Some placed their fingers on the triggers of their shotguns and took aim at Brown's chest. They were exhausted, on edge after the chase and long standoff. They knew only the sketchiest of details about the man in front of them. His blonde hair short, his face twisted in grief and anger. Dispatchers had told them that Brown had been diagnosed with PTSD. They warned that he might have been drinking. Family members told police that Brown had fled his home with 6 weapons, including a semi-automatic assault rifle and several hundred rounds of hollow point ammunition. To one of the troopers with North Dakota Highway Patrol, Brown's intention seemed obvious. Suicide by cop, she thought. He wants to go out in a blaze of glory. As it happened, Brown's state of mind was of interest not only to the cops, but to some of the nation's top military officers and medical researchers. That's why this article has made national news. Brown struggled the most to return to the person he had been before. On that night, last September, his troubles transformed from academic data point to terrifying real confrontation. All the Army's men, all its research, all its treatment had failed to prevent the desperate showdown that would unfold on a deserted stretch of highway just south of the pinched hills of the Dakota Badlands. Now the outcome depended on one distraught man and a half-dozen nerve-racked police officers trying to negotiate a battlefield of the mind that none of them, no one in the world really understood. So this is a real story. I just didn't use his name, but I hope you could get a sense of this. I didn't read the entire story, but the story behind this was Brown, along with, his name is not Brown, but along with 4 other soldiers were in Iraq and encountered a blast. And then they talk about the outcomes. 1 recovered quickly, 2 stayed in military and redeployed, and another got out, tired of the violence, and others gradually improved. But that was story. Now, he survived, of course, but I say that because the outcome could have been different. So that at least they had some collateral information about the diagnosis, that he might have been drinking. But you can imagine if you've been chasing somebody for an hour, you all know more about this than I do, you know, chasing someone for an hour and they've got a gun or guns pointed at you, you know. So these are, and you've heard the term suicide by cop. It's not unique to PTSD. It's very common in urban areas and that. So I read that to you, so hopefully you can have a little bit of insight and sensitivity to the gravity of this problem. Let's move then to traumatic brain injury, or TBI, as I've alluded to in terms of coexisting with PTSD. Now, I'm not going into a lot of detail because this is truly a neuropsychiatric disorder, but with traumatic brain injury, we have mild, moderate, and of course severe. I'm only referencing mild. And most of you have heard concussions. Well, that's essentially what a mild TBI is all about. But it has been labeled the signature injury of the Iraq and Afghanistan wars, the signature injury. And so you hear more talk about it. You're also going to hear more talk about it in sports too, because it's beginning to be more, and it has to be a real phenomenon. You're hearing more about it in boxing. So this has got to be addressed, because when you have mild TBI, most folks don't even know they have it. Well, let me not get ahead of myself, but an estimated 10 to 20% of soldiers who have served in Iraq have suffered from TBI. And again, when I say soldiers, as you know, I'm sure many of you are veterans, that's not even all of the military, because most of these are going to be Army studies. And these are some facts about TBI as it relates to veterans. More than 2 million troops have deployed to Iraq and Afghanistan since 2001. 2 million. It is estimated from studies that 5 to nearly 50% of veterans may suffer both PTSD problems and TBI. Okay? And the ranges are that wide because people are doing research. One study might be 2,000 veterans, another one may be 100. But the point is it's comorbid or coexistent, very common. Soldiers are now experiencing pure blast concussions from the force of an explosion or an IED, rather than secondary effects of, for example, slamming into a Humvee wall after a roadside bomb. What this means is, and again, those of you who are veterans, you know what I'm talking about. I might be in a Humvee, and the blast is over here somewhere, but I feel the shock waves going through my body. It just goes through my body. For some, I'm a little ahead of myself, they may lose consciousness, or some, they just have a little disorientation. But it's the shock wave, so to speak. It's the pure blast sensation that goes through the body. It's not hitting the Humvee, or we have a wreck against the wall, or the actual blast hits the Humvee. You follow? And that's why so many veterans and active military don't know they have mild TBI. Okay? Because you don't necessarily have the history of the actual impact. You may have the history of, and let's move to the next slide. You may have reported, I'm going to move down, that it doesn't cause, well, I'm sorry, TBI usually happens during intense battles that produce trauma, producing both head injury and PTSD. So the big issue here is it causal? No, it's not causal, but it's certainly associated. And so that there is a proven association, but it's very difficult to sort them out because some of the symptoms are the same. As we'll see that, you've got your sleep disturbance, you have the sleep disturbance, for example, in both. TBI does not cause PTSD, but the physical and emotional changes typical of TBI may inhibit a person's ability to deal with a traumatic experience and make it more difficult to recover from PTSD. Again, I won't go into the neurological part of this, but there is actually chemical changes in the brain when that brain, I don't know if you know this, but the brain is almost like a toothpaste consistency. It's a very soft thing, and it literally can move inside the head. It's not, it's attached, but it's not attached. So that it's almost like a mini seizure that goes off in the brain. Let's move to the next one, see if that's the one that I have some of the symptoms. Yes. So mild TBI is associated with the brief duration of a loss of consciousness, or we call it LOC, usually less than 20 minutes, or no LOC, but if you have post-traumatic amnesia of less than 24 hours. So when we're taking our evaluation, we'll ask that, did you lose consciousness? And most of the guys will say, no, I didn't. And that may be the end of it, and people just assume, the evaluator, that the person does not have TBI. But it's important that it is a concussion. Now, there's contusion, but we're not talking about a contusion now. We're talking about a concussion. And there's a term called post-concussion syndrome. But it's just important to know that if the person has PTSD, there may be some IED blasts. And this is the reason this is a signature injury, because this is different from Vietnam. Most of those guys, if they had encountered those kinds of blasts, they didn't survive. Okay? These are dirty bombs. These are more potent, more powerful. So you've got an IED or something going off afar, but you're still getting some of those shock waves, so to speak, yards away. TBI is often associated with personality changes. This is again why the diagnosis of TBI and PTSD are oftentimes indistinguishable. Disorderly conduct, suspiciousness, argumentative, isolative, disruptive, and socially inappropriate. There are intellectual changes, and this is very critical, particularly for people who are in higher functioning jobs, because as you know now, war is an equal opportunity, okay? So you've got physicians, you've got pilots, so you've got people who have to be in professions that really require higher intellectual functioning, and this is what is frustrating. So you have someone who may be a tedious type job, engineer type, but then tells you, I can't even put together a birdhouse, okay? So this intellectual changes are very subtle, may have problems with concentration, memory, attention, executive functioning, planning, reasoning, especially that reasoning. It's almost like concrete thinking for some. Can't process, get upset when the wife or the adolescent child, particularly adolescent male child, if it's a male vet, because they're not processing all that's going on. Some even get paranoid because they've not been home and they really think that they've lost their status in the home, and so that can cause a lot of problems. And then, of course, we've already implied psychiatric disorders, depression, PTSD, grief, survivor's guilt, as you, I'm sure, have heard, suicide, anxiety, and sleep disturbance. And then lastly, physical changes occur. Headache, dizziness, fatigue, tinnitus or ringing in the ears, light and noise sensitivity. If you've ever been on a military base and you see the guys walking in with sunglasses, you know right away, okay, here's a TBI. They've got light sensitivity. I do the boards, the medical boards, and they're coming in, the women and the men. And it's significant. It really is a real phenomenon, that light sensitivity. And of course, noise sensitivity, you can imagine, just like I was saying with the startle responses that you would have with PTSD, where you also can have with TBI. And so in conclusion, while PTSD and TBI require treatment by medical and mental health specialists, it is important that the community, families, and law enforcement have some general knowledge of the disorders, how they affect individuals, and how to make proper referrals to VA or other resources. This knowledge is beneficial when law enforcement encounters these individuals so as not to aggravate the condition and to maintain a safe intervention. That ends my presentation.